To Genomind Grand Rounds. Today's presentation is titled CPIC, New Findings and Current Guidelines. The purpose of today's webinar is really one of awareness. Genomind goes through great lengths. If you've ever listened to any of our previous webinars, we go through great lengths to raise awareness of CPIC and what they're doing. So CPIC is the Clinical Pharmacogenetics Implementation Consortium, and Dr. Kelly Caudle is largely the face of CPIC, along with Mary Relling, but the two of them are really front and center and the face of this organization. I've been part of CPIC for about 2 years now, and what I've seen is that CPIC really does two important things for the field of pharmacogenetics. One, it's the standardization of the field, making sure that everyone is using the same terminology, the same language, making sure everyone is making the same genotype to phenotype translations. Dr. Caudle may speak a little bit about this later as far as recent interactions with the FDA regarding these translation tables. And then equally important, CPIC publishes peer-reviewed pharmacogenetic guidelines. If you go back a few years, 5 or 6 years, one of the criticisms of pharmacogenetics was what do I do with this information? You told me my patient's a poor metabolizer. What do I do with that? Well, Dr. Caudle and her team have created guidelines that spell out exactly what to do in those situations. So, with all that being said, I'd like to introduce our speaker today. Again, it's Dr. Kelly Caudle. I'd like to read her bio. So Dr. Caudle is a pharmacist. She's a PharmD and PhD. She is a board-certified pharmacotherapy specialist. She's the principal investigator and director of CPIC. And again, CPIC provides clinical guidelines that enable the translation of genetic laboratory tests into actionable prescribing decisions for specific drugs. To date, CPIC has 25 gene-based clinical guidelines. Dr. Caudle oversees all CPIC-related projects and the CPIC guideline development process, including the coordination of guideline writing committees, the guideline evidence reviews, and the writing of guideline manuscripts and supplements. Dr. Caudle is involved in the clinical implementation of pharmacogenetics at St. Jude's. Dr. Caudle received her PharmD and PhD from the University of Tennessee Health Science Center and completed an ASHP accredited PGY2 residency at Le Bonheur Children's Hospital. I already mentioned she's BCPS, board certified pharmacotherapy specialist, and is currently an affiliate assistant professor at the University of Tennessee Health Science Center. That is a fantastic resume, a fantastic bio. We're happy to have Kelly here. So Dr. Caudle, thank you, and take it away.
All right, great. Thank you so much for a nice introduction. So I am going to talk about CPIC. Dan had sent me kind of a list of things to go through today. So I tried to stick to that list as best I could. So I'm going to first start talking a little bit about CPIC, what CPIC is. So CPIC, the Clinical Pharmacogenetics Implementation Consortium, was formed in 2009. With what we wanted to do was provide freely available evidence-based and updated pharmacogenetic clinical practice guidelines. Since 2009, our membership has grown to over 425 members of both clinicians and scientists, over 260 institutions. We stretch across 36 countries, maybe more. I think we've got a couple new members over the last couple of days that are from different countries. And then we have 25 guidelines, as we've already stated, and counting. I've got one I'm about to submit, hopefully very soon. And this covers 22 genes and 65 drugs. So as you're maybe aware, CPIC guidelines assume the genotype test is available. I think there's two questions that really clinicians ask every day is should I order this test? Or if you have the information, should I use this test, this pharmacogenetic test? And if I use it, how do I use it? And so this is what CPIC addresses. We do not discuss doing the merits of actually doing the test. So some key points about a CPIC guideline. We've already discussed this, but standardized format. So each one of our guidelines, if you see one, the other one should be fairly similar because we do use standard formats throughout. We have a system for grading the evidence and of the recommendations, which I'll go through kind of briefly today. They're peer reviewed. I send these out to all 400 plus of our members. And of course, it also goes through the journal peer review process as well. So these are certainly reviewed before they hit the website. They're freely available. These are available on the CPIC website, Farmgkb, and PubMed Central as well. They're updated. We do try to stay on top of all of our guidelines as new evidence, as we're told or we discover new evidence, we do our best to try to keep our guidelines up to date. We have a strict authorship policy on conflict of interest, and our practices for writing our guidelines closely follow the IOM practices for writing standards for writing trustworthy clinical practice guidelines. Sorry, that's a mouthful. So we have a website here. I like to show this just so, because I think you can get a lot of information. A lot of what I'll discuss today is right here on the website. We've got some of the slides I'll be presenting today. You can actually get here at the resources tab. But information about CPIC is here. This is our website, the cpicpgx.org. As I said, all of our guidelines are online. If you go to this guidelines page, you'll see that there's links to each one of our guidelines, and each one of our guidelines has its own guideline page where you can get a full copy of the guideline and also the supplement. And then we have a lot of tables and figures that we do provide as resources to help implementers implement the gene drug pair and electronic health record. As I stated, our guidelines are also annotated on Farmgkb. They're also filtered as practice guidelines in PubMed. And again, as I said, they're freely available in PubMed Central. They're also being cited in the NIH's genetic test registry for clinical pharmacogenetics. I'm showing you here TPMT page. This is the condition page, which you can see down here on the right-hand side. They do link to practice guidelines, and you can see the CPIC guidelines here. This is an old screenshot, but I think this guideline's been updated now twice since this, but you can get to the guidelines from here as well. We recently have a partnership now, and you will find links to the CPIC guidelines and then to information on FarmgkB as well. As I stated, our guidelines are we really built them off of the IOM standards for writing trustworthy clinical practice guidelines. In 2014, we wrote a paper about our system and compared it to that IOM standard. And we really do align quite nicely with those standards. So to date, we have 25 guidelines, covers 22 genes and over 60 drugs or 65 drugs. So I know this is a lot to take in, but just wanted to make sure I listed out all the genes and all the drugs in which we have guidances for. So I'm going to talk a little bit about our development process. I'm not going to go into a whole lot of detail here just because of time. I could spend an hour, 2 hours talking about this by itself. But I kind of want to walk you through how CPIC decides, how they're prioritizing, a bit about our evidence review, how we identify our authors, and then a little bit about our evidence review and how we do come to our final conclusions in our guideline. And so it really does start with the guideline being nominated. Sometimes I'll nominate it. I get emails from members from the community, trying to listen to the community. What do they want? Recently, we just did a CPIC survey to our members to see and help us prioritize which guideline we want to work on next. We have resources, but they're fairly limited. So we have to be very strategic about when we start a new guideline, because these can take up to 2 years. And most, I think the average time is about a year and a half from this time we start the guideline to the time that it finally hits the webpage. But there's a lot of work that really goes into deciding how we move forward with a lot of input from our CPIC members. Another big area is identification of the authors. We really need to have authors that don't have conflicts of interest, that have expertise. And I'm going to go through a lot of detail on that here in a minute. And then once we start, obviously we start with our evidence review. I'm telling you, there's conference calls galore for each one of these. So these guidelines are really talked about a lot from our writing committee. And then, of course, that draft is circulated to all our CPIC members before we submit for publication, and then they're posted to the CPIC website. So let me talk a little bit about how we identify our authors. Our guideline writing committee is multidisciplinary, comprising of a variety of scientists and clinicians. So it's really bringing together the ones using the information and understand the disease that you're using the drugs to treat, and the scientists that may know a bit about the gene itself, and the studies that we're reviewing. Of course, there's clinician scientists as well that play both of those roles. But we like to see a track record of publication or expertise in a specific topic area of the guideline. We need them to be leaders in a specific CPIC topic so they can lend credibility to the prescribing recommendations. We do try to have international representation, because not always are drugs utilized the same way in all parts of the world. And then evidence of prior publications relevant to the gene, drug, disease state. We'd like to have at least one or two that have clinical expertise in clinical pharmacogenetics. And then we try to have adequate representation from senior individuals, although junior authors are always great. They generally have a bit more time to do the very time-consuming evidence review. Manage our conflicts of interest through the CPIC steering committee and the CPIC staff. So we do ask for the authors to pretty much submit any type of potential conflict of interest they may see or have to us. It's very broad, and then we review it and we decide if it's something that should be reported in the guideline, or if the patient should be excluded because it's just too much of a conflict. So one thing, the conflicts must be transparent to all the authors and the readers. So before we start the process, the authors get a form that's got all the any conflicts of interest that other authors might have. But we do make sure that the majority of our authorship team should not have financial conflicts of interest, at least at the beginning. Sometimes throughout the process, some maybe start consulting or something. And so we do attempt to do that. It is expected that CPIC guidelines will often have authors who are advocates for using the test information and to inform prescribing. So back to that consult, I do expect that these are gene drug experts, that they are probably doing some consulting, maybe for genetic testing laboratories or big pharma. But I think we would prefer to have those experts be able to be the ones that are doing the consulting. So generally you will see sometimes conflicts where it's just consulting, and it's generally very little money they're making off of doing this. So when you see a list of conflicts, please try to look to see what they are, because most of the time they're very minor if our authors do have them. But of course, conflicts due to employment by any entity in clear conflict will be considered problematic. The senior and first author should not be a person with a conflict. And really, there have been times where we had to ensure the writing groups had the necessary expertise. The CPIC steering committee really has to weigh the disclosed conflicts of interest with the need for the author or the specific expertise. This doesn't happen often, but we are very clear about our conflicts in the paper if we do have any. So I want to focus a bit too about our evidence review and how we draft our guidelines and how we get to that recommendation. So as you may be aware, CPIC guidelines help clinicians translate the genotype to phenotype to clinical recommendation. So we have tables that not only help define what we mean by the star allele, but also that translate that genotype to the phenotype, and then the phenotype to the recommendation, in which we do have a strength of evidence for our recommendations. So I'm going to spend a little time talking a bit about the work that we do on looking at genotype to phenotype translations. So kind of here's a schema that kind of shows really each step that it really takes, and we have tables for pretty much each one of these steps in our guideline. Our allele definition table that really defines those alleles, our allele functionality table. So the way we define phenotype, it really is the combination of the functions of the two alleles. And so, you know, if a patient's star 4, they have two no function alleles, therefore they're going to be a poor metabolizer. But if they just have one, like in our example here, they're an intermediate metabolizer. So it really is you get a normal function allele and a no function allele, which is then going to equal what our phenotype assignment is. And the reason why I've spent a bit of time on this is because the allele functionality table and our translation of diplotype phenotypes tables are now being evaluated by the FDA with the hopes that we can get the tables endorsed by the FDA. So this has been a process. It's been ongoing. Hoping to submit something to them very soon. So keep your fingers crossed, I think, that we're successful here. But the heart of our guideline is really that recommendation. The FDA does not recognize databases that provide therapeutic recommendations. So this is why they're really sticking to hopefully endorsing our genotype to phenotype translations. So before we get to that recommendation, we really have to consider the evidence for that particular gene drug pair. And then we not only, obviously, we look at the gene drug phenotype association studies, observational studies, occasionally some randomized clinical studies in there, preclinical, clinical studies, case reports, in vivo, pharmacogenetic, some functional studies as well. And so sometimes we can have a really strong association between a gene variants and a particular gene and some type of drug phenotype. But we have to also think about the actionability. And at the end of today, I'm going to give a really great example of what I mean by this, and where we had strong data for this gene drug association, but it just really wasn't clinically actionable. So we have to think about really, what is the therapeutic index? So a therapeutic index is where on one side you have side effects, the other side of this you may have efficacy, right? So if it's a really big and maybe some changes in PK aren't going to really translate to increased risk of adverse effects. So yeah, you may have a strong association, but in clinical practice, you don't really see many patients that have these issues. So it's not really that actionable. And then the severity of the disease. How important is it that we get the right drug to the right patient at the right time? We also have to consider consequences of suboptimal prescribing, also availability of genetic tests, because we only discuss what to do if you have the test. If no one's testing it, we're likely not going to write a guideline. And then the availability of and evidence for alternative therapy. So CPIC approaches the gene drug association. Really, this is the first thing we do. The PharmGkb curators over at PharmGkb provide summaries to our authors for each one of the each paper that we find in our evidence review. We do a very broad keyword terms such as CYP2, in this case CYP2C19 and voriconazole. I mean, very simple. Just to make sure we're not missing any important papers. We have 3 independent reviewers that review. And you can see here, one said high, one said weak, one said moderate. These are discussed on conference calls until the entire author group comes up with a consensus for each one of these. And so what these are major findings. In this case, we had 3 papers that supported this particular major finding. So we have high, moderate, and weak, and that's how we list our levels of evidence. I think of high as if we were to do further research, we would not expect the magnitude or the direction of the effect to change. What we have is enough evidence to be confident that that is the correct magnitude and direction of any type of effect. Moderate is where maybe the direction, if we had additional evidence, the direction wouldn't change, but maybe the magnitude of the effect might change. Weak evidence is really where the evidence is insufficient to really assess the effects of health outcomes. And if we were to do additional studies, we would maybe expect the direction and the magnitude of the effect to change. So that's how the authors try to think about this as they're going through this. We do evaluate each individual study as well. We have a process for that as well. So when you see these final, and I'm showing you here the final evidence table from our SSRI guideline here, you can see that all you really see is that final consensus one. But please note that there's a lot of work that goes into how we may design that high, moderate, or weak evidence, or how we assign it. So then we think about the clinical actionability. So we've now gone through our gene drug association studies. Now we're looking at clinical actionability. This is really what you're going to see in that recommendation table in our guideline, where you have the phenotype, and then you have that recommendation, because remember that that the recommendation is based off that phenotype. And again, CPIC provides all the information you need to then translate it to that phenotype. And then we have a classification for that recommendation. I'm highlighting this extensive metabolizer, and I intentionally used an old guideline here so you could see it. We have changed some terminology over the years, and I'll talk about that here in a minute, because this is now a CYP2C19 normal metabolizer. But really, these strengths of recommendations take into consideration, and this is something that I think some people kind of struggle with a little bit, is that we have, a system for grading the recommendation and a system for grading the evidence. And so when it's a strong recommendation, there's evidence is high quality, and it also means that the desirable effects clearly outweigh the undesirable effects. Where moderate may mean that there's a close or uncertain balance as to whether the evidence is high quality, and maybe the desirable clearly, but in this case, the desirable still clearly outweigh the undesirable effects. An optional recommendation is where the desirable effects are closely balanced with undesirable effects, or really sometimes it's just we have really weak evidence, or we're having to base our entire recommendation off of extrapolations. And a lot of times it's we don't have consensus in our author group. There's just a lot of room for differences in opinion to what the need of action is. And so it might get an optional ranking. And then we have the no recommendation. This is fairly new. I say fairly new. I think we've had it for about 5 years now. But this is where we just have insufficient evidence. We have several conference calls discussing how you would act on this based on the evidence. And it becomes very clear that at this point, there's just not much you can do, even if you knew the patient's genotype. I do get a lot of questions about why we don't have more multi-gene recommendations. And we do try. You'll see more guidelines coming out from CPIC. You'll see there'll be multiple genes that are assessed in each one, but it is difficult to assess these together. Because you can imagine how rare it would be to have a CYP2D6 ultra rapid metabolizer, and they're also a CYP2C19 poor metabolizer. So doing studies where you're really measuring both these phenotypes, your numbers are quite low. And so we don't have a whole lot of information that helps provide some type of recommendation for combined phenotypes at this time. But you can see here for the TCA guideline, we did attempt, and you can see why this is optional. But you can see that we did try to provide some guidance based on what we did know about CYP2D6 and CYP2C19. We update regularly. I get emails all the time, people with different evidence, more evidence. We send that back to the authors, ask if there needs to be any type of change to our guidelines. So we do try to stay on top of this. And we do update on our website kind of as needed. And I'll show you an example of that and how we handle updates here in a minute. So we don't really have to wait for an updated publication, even though it would make it to a publication hopefully soon. We have, and you may be aware of this, we've done some updates to terminology as I talked about that extensive metabolizer. And then there was a change in diplotype to phenotype translations for CYP2D6 and CYP2C9. I'm going to walk you through how we got to that. This is not just something that we leave up to the authors to decide. We do take these decisions before we change them very seriously. And so a few years ago, we did, it was called Standardizing Terms for Clinical Pharmacogenetic Test Results. Here's the link to the paper if you're interested. But at the time, we were really thinking about how you could take a CPIC guideline and utilize it in the electronic health record. And it really was, there was a lack of standard vocabularies describing pharmacogenetic results that were really interfering with the exchange of structured interpretations between laboratories, institutions using electronic health records, and patients' personal health records. And it was difficult for EHR vendors to really be able to support efforts to build CDS based on the genetic test or clinical decision support. So those post-test alerts that you see, if you've got the genotype in the chart and you order a drug in which they may have a gene-drug interaction, you get that alert. The other thing is it was very confusing to clinicians, where one patient may bring in a laboratory report that called him a normal metabolizer, where another would say extensive metabolizer. It was really, really kind of a mess, I will say. And so we got together a group of pharmacogenetic experts with the purpose to standardize phenotype terms. We did this for a little functional status terms. And again, those are what the FDA are reviewing right now. But what I think clinicians and what they see, I think some of this the allele function and assign, that's kind of background. But what you probably noticed as a clinician is that you had changes in the phenotype terms. So this was a very long project. I think it took us almost a year and a half, 2 years to completely get consensus on it. Many different phases of this project, but really it was a modified Delphi process where we started with a very huge list of current terminology that was being utilized, and we had a series of surveys until finally 70%, and actually I think we got up to 90% agreed to the terms that our final term set. Our experts, we tried to make sure that we had some representation from clinicians, researchers, genetic test laboratory staff, pharmacogenetics implementers, clinical informatics. This was really important because these terms were then submitted to SNOMED and LOINC. So we wanted to make sure they made a lot of sense from an informatics standpoint. So I think we had a really great set of experts that really did provide, I guess, different perspectives of each one of these genes. So don't worry about reading this. I like to scare people by showing them this, but this is how we started. In round one, you can see how many terms were being used. These terms were pulled from laboratory test results. They were pulled from evidence from the CPIC tables. We pulled it from, we did evidence review, and we really went through papers to see what they were calling these phenotypes, trying to capture as many as we could. And you'll note that I'm just showing you here the drug metabolizing enzymes, but we did look at drug metabolizing enzymes, drug transporters, and high-risk alleles as part of this project. And so we finally, I think after several rounds of discussions, phone calls, survey, metabolizer. And I will say that one point that we went back and forth on quite a bit was this term intermediate. But it was really kind of thought that that this term was so historical that it would be, and it would really, change this term would really disrupt a current implementation that was going on versus the normal metabolizer, because a lot of places were already using that term. So we chose to continue to use intermediate, even though I will say it was a point of discussion with the experts. But we only did it for these 3 types of genes. And now we're moving into guidelines such as RYR1, MTR, and R1 that aren't really pharmacogenetic related type genes. And our terminology is failing. It's not working. It's these terms that we came up for, these don't really work well for more of those pharmacodynamic genes. And so we are working now. We've got another group of experts. We've changed the process a little bit, but just so you know, there's another term standardization part 2 underway. But what we've discovered, it's very different than part 1. Part 1, we had a bunch of historical terms to use. For the genes we're working on now, there hasn't been a whole lot of work on terminology. So in some ways, we are creating new terms. Another thing that we've worked to standardize is the translation of CYP2D6 genotype to phenotype. Kind of took the same method where we did a Delphi, but one of the biggest issues that we had, and I'm showing you here, this is our old CYP2D6 genotype to phenotype table. And you can see that CPIC was calling this activity score of 1 a normal metabolizer, where the Dutch Pharmacogenetic Working Group, that activity score of 1 was an IM. This also came up on CPIC guidelines, where we had to separate out this activity score of 1 from normal metabolizer because we wanted to have an action for it. We knew it was different. And this really was a lot to do with the STAR10 allele. We had a lot of individuals with the STAR10 allele, a lot of studies that were performed in Asia. And so because of that, we had a whole lot of studies with STAR10 and I think STAR5 as well. So we really could evaluate that activity score of 1 quite reasonably for this guideline. And because of that, we ended up having a separate recommendation based on activity score. But we were calling them normal, although you would act on it. Also, laboratories, and I'm showing you here, I sent out a surveyed the labs and asked them how they were translating genotype to phenotype. And you can see that across the board, some were using the CPIC system, and some were using more the Dutch Pharmacogenetic system, and some kind of invented their own system. So because of this, we really knew there was a need to all come together, talk this through, and come up with a system that everybody was somewhat happy with. There's no perfect system, though. There really isn't. We do our best, but there really is not perfection. We call it precision medicine, but it's not that precise. And so what we wanted to do was determine a strategy for defining CYP2D6 phenotype. Again, we use that modified Delphi process, and then we would standardize these terms. We got a commitment from the Dutch Pharmacogenetic Working Group until we finally had consensus. And then it was decided that this activity score of 1 would be moved to CYP2D6 intermediate metabolizer. You'll also note there was another activity score of 0.5 that was added for the STAR10 allele. That was another part of what we reviewed, because we did note that we have quite a bit of data really showing that STAR10 is not necessarily completely non-functional, but does have quite a bit of activity, and it really can influence how you would act on those drugs. So we try to work with groups for standardization as we move forward, because we do understand it's important, but it's mostly through these Delphi processes. So what was the impact of this? So one thing that we really had to think about was how is this going to impact our 6 guidelines that we already had for CYP2D6 at the time. Also, how is this going to impact people who were implementing? How are you going to explain this to patients? So we tried to come up with a system that wouldn't cause too much disruption on normal clinical practice. So here I'm listing out how it affected at least the CPIC guidelines. For coding, the recommendation for IM was the same as the normal metabolizer, except really this, if no response, use an alternative agent. But the good news is we just updated this guideline, which I'll talk about in quite a bit of detail here in a minute. The TCA guideline, this was currently, there were recommendations for CYP2D6 IM, so I went back with the authors and I had to work with them, and then we updated the CPIC website, and I'll show you in a minute. Tamoxifen already had, as I showed you, recommendations for activity score of 1. So that one was already, and so did atomoxetine. So that was great. SSRIs, the IM recommendation was the same as normal. So there really wasn't a need for any changes. And then there was no recommendations for IMs for ondansetron and tripistotron. So didn't impact our guidelines too much. Certainly has impacted our evidence review a bit, because now we have to reorganize our evidence review tables to take this into account. But otherwise, hopefully, at least for CPIC, it was a seamless transition. And I will admit that about 50% of the labs were already utilizing the system that CPIC now uses. These updates, though, and all updates for CPIC guidelines. So I highly recommend that if you go to grab a CPIC guideline, go back to the CPIC website, click on the link, but also look to make sure there's no updates. So if there's a note that we may need to add about any changes to the text or function, or really anything that maybe we have had to readdress after the publication of the guideline, you'll find it here on our CPIC. This is the guideline page for I'm showing you tricycline, the TCAs here. So always try to check here occasionally. And we do put these out in blurbs as well through FarmGkb. You can sign up for that email as well. So right now, the guidelines, and I was specifically asked to talk about antipsychiatric and pain. So, SSRI guideline is right now we're working on the update for this guideline. It will include SNRIs and SSRI-like drugs. I don't know if that's the best term for that, but that's what I'm saying. And then evidence review, we're including additional genes. We're going to do CYP2D6 and CYP2C19 like we did in the original guideline. But we'll also include ABCB1, SLC6A4, HTR2A, and CYP2B6. This does not necessarily mean we'll have recommendations for each one of these. And I'll go through the opioid guideline here with you in a minute. And you can see how when we don't have a recommendation, how that can pan out in a guideline. The TCA guideline, we're hoping to update this in 2022. So I didn't want to go through details. I think there's been a bit of evidence that they'll be able to incorporate into that guideline since we last published. CYP2D6 atomoxetine was just published in 2019, so it's fairly still up to date. And then HLA carbamazepine, this was updated in 2017. We did add an additional drug and an additional variant to that guideline as well. So if you haven't reviewed it in the last few years, you may want to take a look. So I wanted to, in the last few minutes that I have, talk through the opioid guideline. And I picked this as an example because I really wanted you to be able to, because I think with the SSRI guideline, we may have some of those genes that end up with a no recommendation. So I wanted to walk you through what that meant and how we really go through discussing this and how, actually these no recommendations I think take more work for our author group, because I think for you to say not to act on something is sometimes harder than saying that you should. So, which I know sounds crazy, but it really is. So we just got through updating this guideline. We focused it on, it used to be just codeine, but instead now we included most opioids, whatever we had that came up on evidence review, which is why it says select. It's not all, but it is a considerable amount of the ones that are at least used clinically. But we looked at not only CYP2D6, but also OPRM1 and COMT. This was an update to the coding guideline, even though it did include additional genes. So just as a reminder, codeine is activated by CYP2D6 to morphine. So pretty much codeine doesn't have much analgesia effect, and it really needs to be activated by or metabolized by CYP2D6 to the more active morphine. Tramadol, I don't have the figure here, but it goes through pretty much it goes through a little bit of a different metabolism, but it still is metabolized to a more active metabolite. And so I'm showing you here the recommendation for the codeine based on CYP2D6, but it's the same recommendation we have for tramadol. Did not change much from the original guideline where you would avoid codeine in CYP2D6 ultra rapid and CYP2D6 poor metabolizers. CYP2D6 ultra rapid because you are concerned about the risk of toxicity, whereas for poor metabolizers, you are worried about the efficacy. We have this the intermediate group. It's fairly actionable maybe, but we say that you could use codeine, but really if no response and you still want to use an opioid, maybe consider a non-tramadol opioid, and for of course tramadol you would consider a non-codeine. I think the point we're trying to make here is that if it's not working, you may just want to switch to something that's not impacted by CYP2D6 versus continuing to go up on the dose, which may not have an effect. Same thing with hydrocodone as what I just discussed with codeine, except our actionability more is in the poor metabolizer. And you'll see that it's an optional recommendation where we really say that you can use hydrocodone. But again, if they're not having a response, increasing the dose may not overcome, especially in an individual with zero CYP2D6 activity. And so it may be best to just avoid, to switch therapy at that point. And that's the same for the IM. For ultra rapid, we have a no recommendation for hydrocodone. And this was really based on the fact that we didn't have a whole lot of evidence, not many papers that focused on the CYP2D6 ultra rapid phenotype. And so this got that no recommendation, which really means that we can't even tell you can use labeled recommended doses because we just at this time don't know. And that's kind of how we concluded. So other opioids and genes. So the rest of the genes and drugs that were reviewed as part of this guideline, we gave a no recommendation to. So CYP2D6, oxycodone, and methadone. I will note, and this was because of inconsistent and weak evidence, and note that oxycodone also has its parent, it is metabolized to a more active form. However, the parent does have some efficacy, so that may be why the data is quite inconsistent. We will be doing a methadone CYP2B6, B as in boy, hopefully in the near future, because it does seem that methadone is more impacted by CYP2B6 than CYP2D6. So we also looked at OPRM1, which is an opioid receptor. There is quite a few laboratories that do report back OPRM1 genotype. And it's generally this allele here, this 1799971. And we did find, and this is my example from earlier, that we did find a small and a significant decrease in analgesia or increases in morphine requirements in some studies. However, this really did not appear to translate into clinically actionable dose alterations. It was around 10% that you would increase the dose, and we didn't feel like that's really a margin of error. It really wasn't something that you would clinically. Plus, you would increase the dose. So, you know, from a clinical standpoint, you're dosing out opioid. You really want to use the lowest dose possible you can use. So, telling someone to increase the initial dose by 10% doesn't make sense. You could increase up a bit. So this one really got a no recommendation because we didn't think that it was very useful at the time of prescribing. OPRM1 fentanyl, it was interesting. We did have inconsistent results here. They showed that there could be an opposite effect in some studies where they actually may need decrease. But so really it was really inconsistent to the point where the authors concluded there was no effect on fentanyl adverse events or analgesia. With mixed evidence for an association between this and all opioids, but it really is that group of selected opioids, but it does cover, I think, most, if not all, the ones that are clinically used. And found that there really is no effect on opioid adverse events. And we really found insufficient evidence for an association between this genotype, analgesia, and opioid dose requirements. And I want to point this out. This guideline took us almost 2 years to finish. Lots of discussion about the data, lots of going back and forth. The wording in this guideline is very specific to really what the authors and the conclusions of the authors were. I mean, I think that's true for every guideline, but this one, I feel like we worked more on that wording to make it very clear in that guideline how to utilize or not utilize this could be actionable, but right now both of these genes, and we had to give these a no recommendation. So I think I'm at the end of my 45 minutes. So I want to thank the team that we have, steering committee, our advisory board. CPIC is definitely nothing without all our colleagues that work to push CPIC forward, especially our CPIC members and our CPIC guideline authors that volunteer a lot of time to make these happen. None of our volunteers get paid to do this work, and sometimes it could be hours and hours of work for our authors. Obviously, we are supported through the CPIC grant for the work that I do and others, but our authors are mostly volunteers that help support this work. So I thank you for this opportunity to talk about CPIC. I'm happy to answer any questions. I will throw out, though, that I coordinate these guidelines. I may not be able to answer specific questions about why the authors chose to do certain things. Hopefully it was covered in the guideline because I'm certainly not a psychiatric expert. I just help coordinate these guidelines. I just wanted to throw that out there before questions. So thank you.
Kelly, thank you. That was fantastic. We appreciate you joining us. Everyone who's listening in, there's a Q&A box, a Q&A function should be at the bottom of your screen somewhere. Please enter questions in there, and over the next 10 minutes or so, hopefully Dr. Caudle can walk us through some of these questions. While we're waiting for people to add some questions in there, I have a couple. So what we hear pretty frequently is, hey, where is the one source for all the pharmacogenetic information? Where do I go? What's the best, place to go to learn about pharmacogenetics? And more often than not, I'm referring people to farmgkb. So can you tell people the relationship between CPIC and farmgkb?
Yeah, sure. Yeah, we work very closely with farmgkb. It's the farmgkb curators that actually do a lot of the evidence summarizing for our authors. So, and they create our allele definition tape. Well, now with PharmVar, the allele definition tables will be coming from their website, but before PharmVar, they really created it, even though a lot of their curators are working on these tables with PharmVar. So there's a lot of cross collaboration between PharmVar, CPIC, and PharmGkb, but they do all our gene tables, evidence review. So I guess all the background work for each one of our guidelines. And PharmGkb, it's a great resource because you can go in, put in a drug, and you would pull up, if there are clinical guidelines, it'd be a quick way to search to see what guidances there are out there. You can actually put in the gene or the drug, and you get kind of the same, not the same content, but you can find quickly if there are clinical guidelines. But one thing to be aware of with PharmGkb is that if there's not a clinical guideline, they don't really review and provide actionable recommendations. They just summarize what evidence is out there. So until a guideline group really can evaluate the evidence and provide that clinical, remember that whole actionability about it being a clinical, we think about the drug disease associations, which is what PharmGkb is really great at doing, but we also pull in that clinical actionability thought process that really does take that big group of authors to review. So I agree, it's a great resource, a great place you can find the CPIC guidelines. You can even put in your diplotype and it will pull up a recommendation for you. So I think it's a great resource, but we do work together, but just be wary when there's not an actual clinical guideline. It's not going to be it will be helpful because you'll be able to see what evidence is available for that particular gene drug pair, but it's not going to provide you full guidance. I guess that's my point. So great resource, but not, I think the guideline really goes through the caveats, everything that you have to really think about to utilize that genetic test.
Thanks. So just so everyone's aware, both the CPIC website and the PharmGkb website, publicly available. You don't have to register for them. PharmGkb is PharmGkb.org, I think. But if you just Google PharmGkb, you'll find it. And it's great to use them both together. So PharmGkb and CPIC, and we recommend them both quite often. So it looks like we have a couple of questions in the box, but I want to get one more question in because I think our providers would probably be interested in it. On the last few CPIC monthly meetings, there was some discussion about a second generation antipsychotic. I may be misrepresenting that. It may just be an antipsychotic guideline. Can you talk a little bit about that, but probably bigger picture, how do you prioritize the next guidelines that you're going to publish?
Yeah, and I'm sorry, I actually did mean to add that to the thing. That guideline is going to start. We're going to do one on the antipsychotics. I don't know which drugs yet, and I don't know which genes yet. This will be certainly probably CYP2D6, but it will really be up to the guideline authors for them to decide. So on the scope of the guideline, because they already come in knowing at least what evidence is available, and we don't want to waste a bunch of time. Those no recommendations are great, but when we really need to focus on the ones that we think may be actionable first and then move into those. And so we do rely on our authors to help us with scope at the very beginning of the process. So how we prioritize, so we have to think about a lot of things. First, we CPIC members are really great about telling us what they want. I do send out surveys asking our members to help prioritize, in which that CYP2D6 antipsychotic was listed. And I think on the last call, I showed the slide. Overwhelmingly, our CPIC members said we should move forward with that one next. However, I have to consider a few things because we have the curators at PharmGkb that we work with, and then we have the SSRI guideline that's ongoing. And a lot of those authors on the SSRI guideline would also make really great authors for the antipsychotic guideline. And so in an attempt not to overwhelm these individuals, we are going to kind of stagger it. And so we'll do that. We're going to get at least mostly done with the SSRI guideline, and then we'll move into the antipsychotic. So it is a lot of moving pieces and how we decide which one to move forward with, but we certainly do listen to our members as best we can, and feedback from the community. I've been getting pushed on the antipsychotic guideline for a while, but it always seemed like we had the authors wrapped up in something else. And so, yeah, I'm hoping that by the end of this year, we're starting that guideline.
I'm probably a little biased, but I'll push in that direction also.
Yeah, I know.
So we have a question in here. Please don't take this as a gotcha question, but the question is, CPIC currently makes recommendations, dosing recommendations and the guidelines, but they largely remain agnostic when it comes to endorsing pharmacogenetic testing. Is that something that the CPIC leadership plans on changing in the future?
So I think, we have talked about over the years, do we change how we do things? Do we maybe try to include some recommendations if you should test? That is a whole different type of question in which I don't believe there is good data yet to really support when you should use it, what population you should use it in. I do believe the Dutch Pharmacogenetic Working Group is attempting to add this to their guidelines. So I'm kind of sitting back and watching to see how that pans out a bit. I think a lot of clinicians want to see randomized controlled clinical trials showing that using the genotype, these patients have better outcomes than ones that don't. However, a lot of these variants are very rare. You would have to enroll thousands and thousands of people to really be able to see a difference or even get the variants and the phenotype groupings that you would need to even compare because of how rare they are. So it would end up being very expensive to do something like that. In some cases, it'd be unethical. If you could test for DPYD and you gave a patient a 5FU and ended up, unfortunately, maybe killing them, even though you could have tested for that, that would be completely unethical because we have enough data there to really support that these variants are important for drug toxicity. So it's a difficult question. I know it's one people in the community want. I don't think CPIC is, as far as I know right now, we don't have the resources to really go down that road. But I agree. And also I think too, that it could be something that really needs to go more into the disease focused guidelines versus the pharmacogenetic guideline. We're showing you how to use the information if you had it. And I think these, for example, like maybe the psychiatric guidelines, we use that as an example. Including in there, some information about after they've done their evidence review for their guideline, really how you can work, pharmacogenetics into the current workflow. And I think it does need that type of expertise to really think about who and when you should test. I hope that makes sense. I'm not saying that we're completely against going that route. It may be something we do one day, but right now we're going to stick to just telling people what to do if they have that information. And it's mostly because the data may not be there and resources.
Okay. I think we have time for one last question. So you mentioned DPWG before. So, there are other pharmacogenetic consortiums out there. And there are some inconsistencies between guidelines within each consortium. So how do you deal with discrepancies? You touched upon this with 2D6 earlier, but how do you deal with discrepancies between different groups?
So I think we wrote a paper on this actually, and so I can probably send it to you. But comparing the differences in the CPIC guidelines and the Dutch Pharmacogenetic Working Guidelines. There aren't as many differences as you think. Sometimes the wording can be a little different. In the way we do it, but you have to remember too that practices here in the US may be different than practices in Europe. So there could be some changes there in the recommendations. CPIC is generally for some gene drug pairs, CPIC has the most updated guideline. For other gene drug pairs, the Dutch Pharmacogenetic Working Group has the most updated guideline. So you can imagine that in between the few years that we've written our guideline, there could be additional information where maybe the Dutch was able to include that information and vice versa. So they did not have a recommendation, I think, for voriconazole and ultra-rapid metabolizers, or maybe that star 1, star 17, the rapid metabolizers in one of their guidelines. But they admitted that it was likely because they haven't done an evidence review in this in many years. And there's been and it was a star 17 is a brand new allele, pretty much, newly discovered, learning a lot about it, just now being tested. And so there was a lot of new information about it that we were able to incorporate into the CPIC guideline. So I do think there's a lot of reasons. And if you go read that paper, you'll really be able to see that there are discrepancies, but from a clinical standpoint, I don't think they completely would be totally different. I think you could even read both and make a decision quite easily. Sometimes it's just the wording, but rarely I think is it a completely, totally different recommendation, except for maybe the PPIs. They do utilize quite a bit of PK data when they're coming up with their recommendations for the dose, whereas CPIC will rely on papers that have attempted to dose the patients at these and to see if they can overcome their pharmacogenetics, interaction. So, so I think go read the paper. I promise there's not as many as you think, but where there are big issues, such as the genotype to phenotype translation, we certainly are trying to work with them to come up with similar, at least for that, similar systems.
All right, well, that brings us right to the hour here. So Dr. Caudle, I appreciate it. This was a great webinar, great presentation. For those listening, this is being recorded. We will likely post this on our Genomind website somewhere. So again, I'd like to thank Dr. Kelly Caudle, lead investigator for CPIC, and thank you everyone for their attention. Have a nice day. Thanks, Kelly.
Thank you.